Okay, welcome back, students. We are getting into now part two of our chapter 11 lecture. We will be going through slides 47 to 87 today. It will finish out the PowerPoint for chapter 11 for module 106. So, picking up where we left off last time, we are bridging into some new subjects, looking specifically at radiation safety. So, as your lab instructors have been teaching you throughout this entire module, you have to wear protective equipment. And we're going to be looking at that here in the next few slides because we want to make sure that we are preventing things like radiation damage. Radiation damage can have carcinogenic effects. It can cause tissue damage, specifically reproductive tissue damage. And of course, it can damage developing fetus as well. So that means if you are pregnant, absolutely cannot or should not be taking x-rays. It talks about it in this PowerPoint about there being extra protection methods that we can use. Most hospitals just wouldn't have you do them at all with being higher risk with being pregnant. So something to keep in mind and something that I tell all of my students, if you do become pregnant, I don't care who you tell, but you definitely should tell your manager or your a doctor that you work under because you are not allowed to do certain things in our field because it could harm your unborn child. And we don't want that to happen. So things like taking x-rays, cleaning cats' litter boxes, being around some of the honestly, even being in the surgical unit with like the formaldehyde and certain chemicals and agents that we use can be dangerous. And so it's just something to keep in the back of your brain if that ever happens. If you do become pregnant, to please advocate for yourself and make sure that your hospital knows so that they can keep you safe. They won't be telling the whole hospital. It's nothing like that, but they're going to make sure that you're only doing responsibilities that are safe for you and your baby. So something to be aware of. That being said, we wear personal protective equipment when it comes to radiation. So when it comes to, we're going to talk about x-rays, we'll look at MRIs and CTs. Endoscopy, you don't need to have protection equipment because it's just a camera. It's just a scoping camera. But for MRI, for CT, and for x-ray, you do have to wear safety equipment. Again, to help prevent tissue damage, specifically reproductive tissue damage, which is why we wear our gowns, our collars, our dosimeter badges and everything for our protection while we're taking those x-rays. Specifically, radiation damage is known to cause issues within our females, of course, ovaries, which are, we're going to talk about this in the next module, module 101, but ovaries, they're very important organ in the females that are responsible for releasing that egg during ovulation. If ovaries become damaged, then their reproductive status can also be to a point where they might not be able to reproduce anymore if they've had adequate damage, meaning you or the animals that you're working with or anybody that does not use proper radiation safety. And that can be for males as well. It is known to damage testicle tissue and things like that. So, reproductive health, we do not want to damage our reproductive health. Regardless if you plan to use it or not, you want your body to be good and in working order and healthy. So, abiding by these safety procedures that we're going to talk about is super important. And again, I know that your laboratory instructors have done a phenomenal job of going over this with you and talking about the safety of radiation and the equipment that we should be wearing. Now, I do want to highlight some terminology that you should be aware of with radiation safety. So these are some abbreviations and terms that you should be aware of when it comes to radiation. REM, this is Roentgen equivalent man. This is how we monitor and measure radiation. And I'll give you an example of that here within the next few slides about what is maximum amount that you're allowed to be exposed to. A sievert, that's SV, and that is equal to 100 rems. A millirem or an mrem is 0.001 rem. A rad is a radiation absorbed dose. Gray can be abbreviated to GY is equal to 100 rad. 1 rad is equivalent to 1 rem, and the maximum permissible dose, MPD, And last abbreviation here, as low as reasonably attainable, ALARA. And that's what we shoot for is ALARA. We want to be as exposed as reasonable, as low as reasonably attainable. So taking as little x-rays as possible for our patients. We shouldn't have to take 10 x-rays to get one good shot. We should be positioning them well enough and restraining well enough and doing our job well with our measurements and everything that we get the perfect x-ray on the first or second try. If we're having to take 10 x-rays to get one perfect image, we're exposing ourselves unnecessarily. Now, ones that I would be aware of, I would definitely memorize REM and ALARA MPD. Those are important to know. Now, when it comes to REMs, you do have maximums that you're allowed to be exposed to. So in the field, you will be wearing a dosimeter badge. This is a little badge that will clip on to your lead gown or lead thyroid collar, and it's going to have your name on it. So you're going to clip that to yourself whenever you go to take x-rays. That badge will measure how much radiation you've been exposed to. It'll measure your REMs. We will send these badges off every quarter. That's every 3 months. They get sent back to the company and they will tell us how much radiation we've been exposed to, and they'll give us new badges. And that is to keep us under the minimum or the maximum amount per year. So we're not allowed to go over 5 REMs per year for occupationally exposed people, which is you. As somebody who has a job in veterinary medicine, your occupation requires radiation, dealing with radiation, with x-rays, MRI, CT. So be aware that, again, we're at that 5 REM. Now, if you didn't work in a field where you're supposed to be exposed, your exposure should be less than 0.5 REMs a year. And if you're pregnant, it should be at 0.5 as well. So that means that you can be exposed, but you really shouldn't. A good hospital or practice wouldn't expose you at all, because it's too big of a risk for you and, again, for that developing fetus. It's too big of a risk. There is extra radiation safety badges and stuff that they can have you wear. I'm going to be really honest. I've never seen a hospital have pregnant women even be somewhat remotely near the X-ray machine, again, just because of those possible side effects. So not something that you're going to see or should see. That would be a really big red flag for me. Working at a hospital and becoming pregnant and then wanting me to still take X-rays, massive red flag. I'd probably go to the state veterinary board about it. Now, with our occupational exposure, we wear personal protective equipment, PPE, for minimizing this exposure. So what we usually wear is lead shields in the form of gowns, gloves, thyroid shields. They even make glasses. I've never worn them, but I've heard of them. Yeah, I've never worn them. It's not something that I've seen commonly used. But I know that they're out there and that they're available. It's not a requirement for you to wear glasses, but the gowns, gloves, and shields are requirements. Now, another thing about taking x-rays is you want to increase your distance from the primary beam. So usually there's 1 or 2 people restraining the pet, and we're right there holding the pet, right? The x-ray beam is shining down right on that animal. You're within usually a feet or 2 feet from that beam. We want to limit that as much as possible and wear your gloves and things like that so it's not just your hands and everything being exposed. And that's going to help us minimize our exposure rates. We can also use things like sandbags or tape or gauze muzzles and certain other restraint tools to help us with restraining for x-rays. And sometimes our patients are fully sedated. And that's the case quite often. We do sedate quite often for certain types of x-rays, or if the patient's aggressive. Sometimes we do x-rays post-surgical procedure to make sure everything's done correctly. So, and of course, we do full dental x-rays under anesthesia as well. We also want to use fast film screen combinations. Again, just limiting our exposure time to how much x-rays we're taking. Again, if the doctor just needs a 2 view, we want to try to get that within 2 images. We don't want to have to take 10 images to get 2 different ones. We would like to do that with the least amount possible. Another part about minimizing occupational exposure is by, again, not being in the primary beam or to use a collimate as well, which can help with that scatter radiation. Y'all were researching that a little bit this week slash last week with your discussions. Also, again, reducing the number of repeated shots that we're taking, using technique charts can be helpful. Proper darkroom technique. We're going to talk about dark rooms in just a moment. Now, your hospital should have a radiation protection supervisor. This is more than likely your hospital manager, and they will be in charge of safety education. They'll be in charge of maintaining radiation safety badges, so those dosimeter badges that you'll get. And they'll be also responsible for maintaining the equipment, so making sure that our gowns and collars and everything are in good workable condition. They're not cracked or anything like that, and that we've got the amount of proper sizes we need for our clinic and that we're keeping up to date with our state regulations. And we use OSHA all the time to, they'll be the ones primarily updating us about the occupational hazards that we face and the guidelines that we need to follow for safety. I go into OSHA oh my gosh, a lot. We talk about OSHA quite a bit. That's going to be in module 100. Which is, it's not after this one. It will be 2 months from now. And OSHA, for those of you that didn't know, OSHA stands for the Occupational Safety and Health Administration. They are not just in vet med, they're not just in human med, they're really in every single job field that you could ever work in. And they're the administration that sets these safety guidelines to reduce the hazards that we're exposed to. So we follow OSHA's guidelines. As well as if your hospital's accredited by AHA, they might also follow AHA guidelines too. Now, in these next few slides, we're gonna start to look at dark rooms. As I said previously in part 1 of this lecture, it is to the point where these are obsolete. We don't use them anymore. I'm here to teach you, it's a history lesson today. We're going to go into vet med 20 plus years ago. Because when I first started in vet med about 15 years ago, these were already becoming obsolete. I never even personally got to work with one. But I did learn about them when I was in school as well. But that was also when digital X-ray was booming and everyone was upgrading to it and they were getting to those newer and better systems, those cassette systems and everything. And so, will you see actual films anymore? No, you won't. They don't sell them, they don't make them, it's not a thing. Not in the United States, you're not going to see it. If you were to volunteer or practice in countries that don't have modern medicine practices, you might still see them being used. But here, you're just not going to see it. We have moved past it. This is considered to be basically history, unless you take a photography class. If you take a photography class and you're actually like developing films with photography, yeah, you're probably going to learn all about dark rooms and all of that. But for the majority of us who probably will never do that in our lives, you'll probably never see this in person either. It's something that we used to have to do when we took x-rays. We had to use actual film and we would go into this dark room, dip it in all sorts of different chemicals to develop it and process it, and hang dry it. It would take almost a 2-day process to get the x-rays back. And they were, live films, physical films. They weren't digital, nothing of the sort. So only one person could have that copy at a time. It was a totally different world. Back in really before the 2000s was when this was primarily a thing. In the 2000s, early 2000s, that's when medical advancements started happening. We got into digital x-rays using cassettes and dark rooms became obsolete. By 2010, they really weren't being used at all anymore. Now, I am going to talk about this because I am required to, But again, sit back, relax. We're going through a little bit of history. This is not stuff you have to memorize. This is not stuff that you need to know for practice nowadays in 2025, or future. It's just not a thing anymore. But let's learn a little bit more about it. So when you're developing these films, you have a dark room. This is where you're going to develop those films because if they're exposed to light, it will ruin your films, completely ruin them. So we have things like a dry bench, a wet bench, and we use this for loading, unloading cassettes and processing these films, drying these films, storing them. So we're going to go through quite a few slides about film processing, the chemistry behind it. Again, take this information as you will, as a little bit of a, like I said, like a history lesson. But just know that you don't have to take, you know, a lot of notes or anything on this section because you will not have to do this. X-rays nowadays are so easy. It's a going to a computer, crunching in information about that pet, punching in a few numbers from your measurements, and you're good to go. And you press a button, it takes the image and it pops up on the computer. It's incredible. But that's not how it used to be. How we started with X-rays was using actual films. And when we labeled our film, we actually would write on this film to label this film. Nowadays, it's so easy with digital X-ray. All you have to do is enter it in the computer. So you'll enter information like the patient's name, the client's name, the clinic and ho or hospital that you're at, the date, the area that you're imaging, the species. That's typically what you would enter into your X-ray machine before taking these X-rays. Most X-ray machines are so advanced nowadays, they're already connected to your regular computer system, and it will, you can search them on that computer and just, it'll automatically load all their info. It's really advanced. It's quite incredible, especially if your hospital uses EasyVet. Their system is flawless. There's a lot of systems out there, but that's one that's personally a favorite of mine. Now, when it comes to film identification, how do we read films? How do we identify them? We don't have to use things like photo or manual labelers or printers anymore. Everything is all digital for us nowadays. However, you may still be using lead letters or radiopaque tape. Letters, we set these down. We have an L and an R and they stand for left or right. Because when the patient's laying down, like in dorsal recumbency on their back to get an x-ray, or maybe they're in lateral recumbency on their side, we need to know which side is which when we're reading the x-rays. And when I mean we, I mean the doctors. They will need to know which side it is which when they're reading those x-rays, especially when they're in lateral recumbency. The reason for this, when a patient lays with their left side down, their organs will stack differently on top of each other than if they are laying right side down. Our bodies are not made symmetrically, and there are certain organs like the heart that track to the left. So orientation matters. It matters which side they have up or down, and that's also why you need to label that when you're taking these images. So if I had a patient left lateral, left side down, I would want to put the L marker down on the table so that when I take the image, the L marker shows up on the x-ray image and it's easy for the doctor to see which side that they're looking at. We can also use tape for labeling and for also helping keep the patient in place when we're taking those x-rays. But again, you won't have to manually print or do photo labels or anything like that because it's all digital. You could technically add a left or a right on the image once you take it rather than using lead letters. I personally like using the letters. That's just my opinion. Safe lights provide working light when you're in a dark room. So image here of that dark room, you can see it's like a red light. If they have regular lighting in that room, it completely ruins the film. And so they had to have certain safe lights so that they call it fog the film. And have different direct or indirect lighting methods. Filters can also be used, like you saw that red light filter. And it all depended on the film that you were using and the types of developers and fixing agents you were using. Now we're going to look at that within the next few slides here. Again, this is just some information about film processing. So we would use developers. Developers will convert sensitized silver halide crystals to black metallic silver, and that's what helps develop on that grayscale on that film. So it's that chemical reaction in those dip tanks. Now, we use certain components like solvent, which is usually water. We'll use reducing agents, which causes the change to black metallic silver on the films. We also use restrainers. These protect the unexposed silver halide crystals, so the ones that didn't get activated by that radiation beam. We use activators, and activators help soften and swell film emulsion. And we also use preservatives, which help prevent rapid oxidation. Continuing on with more chemistry for film processing, we also use fixers. These remove unchanged silver halide crystals from film emulsion. They leave only black metallic silver, and they help harden film emulsion. Some more components of that are going to be, again, the solvent being water, fixing agent, which will help clear the remaining crystals from emulsion, acidifier, which neutralizes alkaline developer, a hardener that hardens emulsion and shortens drying time, and preservatives that prevent decomposition of fixing agents. Now, usually this was done manually, which means that somebody had to be in that dark room processing these films and timing these films and making sure that we were moving all of these films from one chemical to another at the appropriate times in order to develop these films correctly. This was a really time laborious process. Took a long time to develop x-rays. If we took a film, it could be 2 days before it's completely finished and ready and developed. And it takes staff members away from doing other things to be completely dedicated to working in this dark room, not to mention chemical exposure, really high risk chemical exposure doing this type of stuff. So I'm really glad that it's not a standard anymore, and that we've definitely advanced with our technology in that, because it is a very tedious process. Again, as you saw with all of those chemicals and fixing agents and all of that, a lot of it goes into it. It's a timed process. And if not done correctly, the x-rays are completely unusable. So a lot that goes into that. Now, automatic processing, if someone was ever lucky enough to work at a hospital that had that, vet med didn't really have those kind of things. Possibly laboratories maybe did, or bigger hospitals. But that would be like a processing machine. Of course, it's going to be faster than manual processing and somebody doing it for you. So it would do the same exact thing, but it usually eliminates the processing errors because it's timed. It's a machine. They don't usually make the same errors that humans do. It is special film and processing agents you'd have to use for automatic processing, but it definitely was a perk if it was available. Now, for silver recovery, this is important because it's that silver reactions that give us those different grayscale appearances when we're looking at these x-rays. So when developing these x-rays, there would be unconverted silver halide crystals left over. So we would need to then remove them from the film in the fixer because it would build up and get reclaimed. And so it's just something that we had to do quite often, in addition to maintaining all of the chemicals in darkroom. Now, when it comes to radiographic artifacts, moving away from film developing, radiographic artifacts can happen to anybody taking any kind of an x-ray. These are unwanted blemishes or densities on a radiograph. So basically, it's some type of speck or blurriness or obstruction. Something is in your x-ray that's blocking it. This could be because of improper film handling, exposure, processing, darkroom issues, not going to be a thing anymore. What you're going to see nowadays with digital x-ray is if you do have artifacts, it's usually because your patient's dirty. And what I mean by that is I've had patients come in emergency that were like hit by a car, and they were just covered in gravel and dirt and things like that. And that absolutely can impede an x-ray. So if the patient's dirty, covered in mud, dirt, gravel, if they have a leash or a collar or a harness on or a halter if they're a livestock or horse. Absolutely, that can impede the X-ray. Or if they have bandages on, if we're using restraint tools, those can technically impede the X-ray. Um, Anything like a trough, other things like that can impede it. So, does that mean we shouldn't use those things? Not necessarily. We just have to be smart about it and use it in a way to where our images are still being able to be read and the artifacts aren't completely distorting those. And if we're able to remove the artifacts, then that's what we're going to do. Standard, whenever you take x-rays, you're going to be removing leashes, collars, harnesses. All of that does come off the patient when taking x-rays. And usually we're not x-raying through a bandage. We'll remove the bandage and then take the x-ray because the bandage material will impede it. This is just a picture of some positioning terminology for your radiographs. I have an entire lecture about this in your module under the lecture section under supplemental PowerPoints. There's two PowerPoints. One of them is a directional terms PowerPoint, and another one is like a radiology positioning PowerPoint. And both of those talk about how to restrain pets and position them for certain types of x-rays. Basically, what your lab instructors went over with you, but I do have those if you are interested in looking at them. That being said, as you went through this module, it's really important that you're memorizing these directional terms. We're going to talk about these terms in Module 101, which is your next module as well. So be aware of these terms, be memorizing these terms. You don't really need to know those abbreviations next to them, but you should know you should know what ventral is. Where is ventral? You should know that that's the stomach area, right? Or that would be, laying on their belly. You should know that dorsal is their back. You should know that lateral is laying on their side. Medial is closer to the midline. You should know what these directional terms mean. And if you don't, write that down. Write it down as something you need to go memorize and be putting more attention on because we're only going to build off of this as you saw in this module. And if you don't know your terms, you will get lost very, very quickly. So very important that you're reviewing those. And I'm going to have quite a bit of information about this in our next module. So be looking forward to those PowerPoints in that mod as well. Now, sometimes we get oblique projections. This can happen usually because there's improper cassette placement or improper beam placement when we're taking x-ray. That being said, it only usually happens with older machines that have separate cassettes that aren't connected to your beam, which means that it doesn't move at the same rate of pace as your X-ray beam does, which means that the settings can be off and this and that. Um, Most machines nowadays, everything moves together in one piece. We don't usually see very many projections. If you start to see projections, always try to adjust your viewing window and see if that helps a little bit with that and possibly move up a cassette size. It might need a larger cassette to absorb the image if especially if your beam is at like its largest setting. You don't want a cassette size that's smaller than the beam and for the image that you want. When it comes to contrast, so x-rays and most of these diagnostic imaging tools are going to be on a grayscale. The only thing that isn't on a grayscale that we're going to talk about today is endoscope, and that's because it's a camera. It's not using radiation to get images of the patient. It's different, but it's still an imaging tool. All of the rest of them, I'm talking about x-rays, ultrasound, MRIs, CT. All of those are on a grayscale and use contrast studies. So, on the grayscale, we have all the way our darkest color being radiolucent. So, that is how a doctor would refer to that. Darker colors on an x-ray are radiolucent, lighter colors are radio opaque. That's what you're going to see written on an x-ray report describing certain areas. Now, it's important to know that radiolucency, when you see something that's radiolucent, it's usually air or fluid, like blood or urine or just chest fluid, things that are fluid throughout the body, air pockets. That's going to be on the radiolucent side. Halfway through our grayscale, usually is our soft tissue organs, some of our more cancellous bones. Long bones are kind of in there. Then, as we get more to the radio opaque side, we get down to bones. Dentin, I'm talking about teeth, enamel. We also see metal restorations, which means if your pet had an orthopedic surgery and had plates, screws, pins, any of those things placed in their bones, they will fluoresce when we take that x-ray. They're going to be bright, bright, bright. Metal is super bright on any x-ray, brighter than bone. And so it depends on how solid the material is that you are imaging. It depends on how thick the area is that you're imaging. But that's how we're going to be reading that grayscale. So again, radiolucent is darker on that grayscale. Radio opaque is lighter. Radio opaque is also known to be a positive contrast media versus radiolucent is the negative contrast media. I would memorize those terms. And again, radio opaque is white or near white, and then radiolucent is that darker and could be black in color, but just getting darker on that grayscale, fading that darker gray all the way to completely black. So let's look at positive contrast media here real quick. And again, positive, this is radio opaque. So that means that it's white or near white. So we're looking at more of the bones, metal restorations being in that positive contrast media. So this, we are looking at a high atomic number with our positive contrast. So therefore, positive contrast absorb more X-rays. That's why we see them fluoresce and get really, really bright. Now, we also use a type of positive contrast media in diagnostic testing called a barium study. That was one of the topics for the term project. I'm not sure if anybody from this class chose it, but barium studies are when we give the patient barium. This is usually oral, so it's going to be by mouth, like a barium paste, and they'll swallow it and it will then go through their digestive tract. And we will take images as it's moving through their GI tract. Excuse me. And we do this to try to see, is there a foreign body? Is there something stuck? Is there a perforation? We might do this before going into an exploratory GI surgery. So let's say we think the animal ate something they shouldn't, maybe a foreign body, usually a toy. It's usually toys. So let's say we think the dog ate part of its rope toy. We did an x-ray. We didn't quite see much on the x-ray, but that doesn't mean that it's not still in their system and possibly stuck in their intestines. So before cutting them open, we could do an endoscopy if they had just swallowed it, like within 2 hours. Otherwise, it's already gone and passed through. Or we can do this barium study. And the barium, as it travels through the intestines, are going to be super bright white. And so if it gets stopped by anything, it's gonna very clearly show where that impaction is. So it can be really, really helpful for knowing where that problem is, or if impaction is even a problem, or perforation. Versus we can also use, instead of barium, we can also use a water-soluble organic iodide. Same type of thing. It's going to fluoresce when we take x-rays of it. It'll help us show perforation of the GI tract, and it's also fast moving through the GI tract. So that's just another method to use if they didn't do barium, but the only type of studies I've done involved barium. I haven't worked with any other materials besides that, as it's the most common, but there are others out there. Now, negative contrast media. This is the lower atomic number. So remember, lower contrast media is going to be radiolucent, which is that darker in color, right? We just looked at radio opaque. Now we're looking at radiolucent. So darker in color, that means the x-rays pass easily through. So it's usually fluid or air. Air, oxygen, carbon dioxide, fluid, blood, urine, you name it. That's usually what's going to be negative contrast. Okay, before we get into ultrasound here, we are going to go on a small break. And then when we come back from the break, we'll get into ultrasound and talk, and then we'll also talk about CT and MRI. But we are going to pause for just a moment. All right, students, welcome back from your break. We are now getting into a new topic for your chapter 11 with diagnostic imaging, and this is using the ultrasound machine, also known as ultrasonography, which is a non-invasive soft tissue imaging technique. And they use this technique. In addition, with x-rays, this is definitely a lot better for, again, soft tissue imaging. So if they're trying to look specifically at the organs, the kidneys, the stomach, the liver, the bladder, soft tissue organs can be fantastic for that. Versus we might want to use an x-ray if we're looking at more of our orthopedic, right? Looking at the bones and structures. It can be good for soft tissue, but we don't tend to see a whole lot on X-ray. Ultrasound can be that better option. Um, Now, with ultrasound, we use a transducer. That's that little wand that she's holding in her hand. And that transducer produces low intensity, high frequency sound waves. These sound waves are sent into the soft tissue, and the sound waves reflect backwards. And some of them travel deeper, most of them reflect back, and these reflected waves transmit into echoes. Echoes are received by the transducer, and then the computer produces them on the grayscale image, which gives you the image that you see up here on the screen for the ultrasound. And again, just like your x-rays, it is on that grayscale. Same rules apply on that grayscale for ultrasound imaging. Let's look a little bit more at our transducers. So transducers emit sound pulses. They also receive returning echoes. They convert echoes into electrical energy. Um, this can be done in a mechanical or an electronic process. It kind of depends on the type that they have. They're just like with X-ray machines, there are different manufacturers and brands of these ultrasound machines as well, and they can be made differently with different types of scanners, different types of, again, mechanical, electronic, frequencies. You don't really need to know the differences between machines unless you wanted to go into the market of selling veterinary products. But what you do need to know is that, again, specific to your machine, your transducer, all of that, it'll be manufactured for that machine, and your hospital will select one that is a good fit for them. If you work at a specialty center, you might be working with a very expensive ultrasound, especially one that's great for cardiology. So anything looking at the heart, those are usually more advanced machines. Versus if you're at a general practice clinic, you might just have a little handy dandy portable ultrasound machine. Both of those machines can still work fantastic and give us great detail about diagnostic imaging and information we might want to know. It just depends on what's suitable for your hospital. These are not cheap machines. X-rays that could be 100 grand to invest. An ultrasound, that's a good 30 to 40,000. It could be more. Um, MRIs and CTs, you're looking at a quarter to a half a million to even more, depending on those types of machines. So these are not machines that are a light purchase for a hospital. They're going to invest in one that fits their needs for long-term purposes because it's a large investment. So usually you don't see them updated very often either. They're built and meant to last. And you could still buy like more of those transducers to replace them, and replaceable parts for your machines. But I've seen machines in use for, 10, 15 years. Um, it probably even longer now, with the new technology that's coming out. Now, when it comes to the displays on ultrasound, there's a few different modes that you'll see. Again, you will not be the one reading ultrasounds. You'll be restraining for this procedure. So you'll be the one holding the animal, monitoring them, making sure that they're comfortable, helping the doctor. But it's going to be the doctor that's doing the ultrasound and capturing the images up here. Um, and they'll be reading them as well. Now, sometimes, and most of the time with x-rays too, actually, they'll send these diagnostic images off for a radiologist to review them. Radiologists are doctors that specialize in radiology. So they specialize in reading diagnostic images. They went to school and passed more board examinations. They have like 3 or 4 more years of experience plus another residency. So they do probably 7 more years of schooling to become a radiologist. It's pretty intense. I have one friend that is a radiologist, that I met them when they were in their internship from vet school. Anyways, and these are the doctors that usually read these images. Now, general practice veterinarians can do light reading. And maybe if they've taken some extra courses, they can do it a little bit better. But most vets will send these images off for eval. They won't even read them themselves. General practice, they don't usually. They can usually read general x-rays, but again, most of the time we're sending it off for eval. Also, just to make sure that we have somebody who is a specialist review them and really give their detailed report. So again, we've got some different modes depending on what they're looking at. A mode, which will show returning echoes displayed as like peaks on a graph. There's B mode, which uses like pixels or dots that are all over the screen. There's also M mode, which is like a continuous display of the organ, which is usually something we use in an echo or echocardiography, certain tests that will run on the heart. There are some different terms to be aware of when describing echo texture. Not necessarily something that you need to memorize, as you're not the ones reading the reports and interpreting them, but still terminology nonetheless. So we'll kind of talk through some of these terms here. So echogenic, or echogenicity would be another way to say that, is the ability to bounce an echo. So it's the return signal in the ultrasound exam, right? It's what comes back. So in other words, echogenicity is higher when the surface bouncing the sound echo reflects increased sound waves. So tissues that have a higher echogenicity are called hyper echogenic, and we're going to look at that a little bit later, the hyper versus hypo. And it usually means that they're represented with lighter colors on the images in a medical ultrasound. Anechoic, so anything that you see that starts with an A or an AN. We're going to go over this in your next module. Module 101, we're going to look at all of your terminology, and I'm going to break this down for you with scientific terms and how to know what they mean and stand for. So anechoic, this means A or AN means to go without or not have any. So anechoic means without echoes. So no more echoes. These areas appear black on the ultrasound because they don't send back any sound waves. Something that's hypo, so hyper echoic. Hypo is like low and slow, not operating very well, versus hyper is like over excessive, overactive. So hyper echoic means that there's not that many echoes. Hyper echoic means there is a lot. If something is sonolucent, this means that it contains few or no echoes. And if it's isochoic, this means that it returns an image that reflects the signal, same as adjacent structures. So again, do you really need to go forward and memorize all of these terms? Not necessarily, but it is good to know your terminology, and to get familiar with these terms, all of course. Now, to put it to a little bit more of a image for you, I've got kind of a breakdown of what a hyperchoic versus hypo versus iso would look like. Again, overactive, underactive, semi-active with those echoes. I will be following up with a video as well to give you a little bit of a visual look at what that imaging is specifically looking at when looking at some of the soft tissue. Now, patient preparation. We have to prep our patients for this. It's not like an X-ray where we can just go do the exam. If we are ultrasound any part of the body that's part of the GI tract, so the stomach, small intestine, large intestine, we need to fast our patient. meaning they should not be having food for 12 hours before the ultrasound exam because we need the food to move through the GI tract in order to view the organ. We can't view the organs properly if they're filled with food. So patients should be fasted at least 12 hours. Water is fine, but no food. Um, some vets don't even like water, like at least a few hours before, because it can also still impede it. We also want to make sure that the transducer is in close contact with the skin. So we're usually going to shave the patient. So we'll shave the area that we're ultrasounding. Most common ultrasounds are abdominal or thoracic ultrasounds. So they'll be on their dorsal recumbency on their back, and we'll shave that ventral aspect of them. We also want to clean them, so remove any loose hair, dirt, things like that. And then the doctor will either use a ultrasound gel, like an acoustic coupling gel, or they could use a just isopropyl alcohol, 70%. That's pretty common. I worked with a lot of doctors that preferred alcohol over or isopropyl alcohol over an ultrasound gel. And a lot of that comes back to preference. However, you will use isopropyl alcohol if you're doing any type of synthesis. So if you're doing a abdominocentesis, a cystocentesis, a thoracentesis, and that's pulling fluid out of any one of those regions. And again, don't worry if this terminology, if you don't know what I'm talking about, because we're going to learn all about that soon. Thoracentesis, that's on the chest region. Cystocentesis, I'm talking about the bladder. Abdominocentesis, the abdomen. So that's pulling fluid from any of those areas, usually through a needle and syringe or getting a biopsy or sampling. Of course, you'd want to use isopropyl alcohol to use your aseptic technique. Otherwise, ultrasound gel could be just fine. Again, it's honestly all in preference. And no, we cannot do the ultrasound with them having full hair. It does not work. They do have to be shaved. I always get owners or people that ask that, like, oh, you know what, if it's short hair, it doesn't matter. We got to shave them. We need it as close to the skin as possible. The hair will grow back. Now, artifacts can also happen on a ultrasound. So you can see these two little black dots that are here on this image that I'm showing you. That's acoustic shadowing. So it can be due to a lot of different things like bone, colliculi, mineralized tissue, fat, issues with our machine. Doesn't really mean too much here. Again, this is why and you can see even just like the impeding right through here, you can see that, again, if you don't know what you're looking at, you wouldn't know if something's wrong or if it's right or if it's wrong. So this is why we have radiologists. This is why we send these off for evaluation, especially ultrasounds. They're actually a lot more complicated to read than your x-rays, especially because we're looking at different species, right? It's not like we're just focusing on dogs. We have dogs, cats, so many different species depending on what side of the field you're working in, which also makes it more complex. Now, sometimes we find artifacts that don't have any diagnostic value, which could just be like a slice thickness artifact or a mirror image or things like that. And what I'm talking about is like little lines that you see that go through the image or little like curvatures that go through. Those are reverberation, and you're looking at a mirror image artifact. These mean nothing. They are usually just due to settings on your ultrasound, possibly issues with your transducer if it's old or needs replacement, quality check. That being said, we're going to ignore those type of artifacts versus ones that actually do have that value. Okay, before we get into endoscope, I do want to show you all really quickly just a quick little video about ultrasound, abdominal ultrasound in dogs and cats. That's, again, abdominal is going to be the most common place that you will ultrasound. So we'll start this video here, and then we'll go back to our slides looking at our endoscope.
Ultrasound is a safe, non-invasive procedure that uses sound waves to produce images of the body's internal organ systems. When you see a photo or a video of an unborn baby, this is from an ultrasound. The accessibility of ultrasound has revolutionized veterinary medicine and become a powerful diagnostic tool in the last 10 years. Although both X-ray and ultrasound produce black and white images, X-rays are more like a silhouette photograph, while ultrasound provides a video in real time showing the internal structure of the abdominal organs. When ultrasound is used to examine the heart, it's called an echocardiogram. Ultrasound is a structural exam that can often show changes in the body even when blood work is unremarkable. Patients are positioned for the exam on the side or back. The area to be examined is shaved and gel is applied to improve the image. During the procedure, we keep the patient comfortable, speaking quietly and petting them. Rarely is sedation or anesthesia needed. It takes approximately 20 minutes to perform a typical abdominal ultrasound. During the examination, the doctor is looking for any structural changes to the organs, masses or tumors, enlarged lymph nodes, or the presence of fluid or gas within the abdominal cavity. Ultrasound is also a very effective diagnostic tool to determine obstructions of the stomach or intestines, as well as evidence of obstruction of other tubular structures, such as the common bile duct or ureters. Using ultrasound, we can also search for stones within the urinary bladder or other parts of the renal system. If the veterinarian finds an abnormality, such as a nodule, mass, or fluid, a fine needle aspirate may be recommended. This procedure involves guiding a needle with ultrasound into the area of interest and collecting a small sample. We also use ultrasound to guide removing large amounts of fluid. Sometimes ultrasound is the key diagnostic test we need to help your pet, possibly avoiding more invasive steps, like surgery. Other times, ultrasound can help us know that the other steps are needed.
Okay, so that was it for that ultrasound video. We're going to come back into our PowerPoint here to now get into endoscope. All right, so talking about the endoscope procedure. Endoscopy is the only procedure that we're talking about in Chapter 11 that does not involve radiation. It is quite literally just a camera at the end of a very, very long insertion tube that we can use to insert to different openings of the body. Specifically, it's usually going to be um, an endoscope exam that goes down the esophagus into the gastrointestinal tract. That's traditional endoscope or gastric endoscope. We could also be doing endoscope of the airways or respiratory, rhinoscopy up the nose. So there's, of course, different places that we can image, colonoscopy up into the rectum, large intestine if we needed to. So it is an imaging tool used in diagnostic testing. And it's really great for sample collection, biopsy collection, and it's a non-invasive tool, which means it's something that we can use before going in surgically, which is great to get kind of a view of the inside of the body without having to cut. And there's different types of endoscopes. There's rigid and there's flexible. So we'll look at the kind of different types here. I do have some videos that I will show you, one of large animal, one of small animal, because I want you to see a little bit more of what that procedure looks like. Now, in small animal medicine, they're usually sedated. In large animal medicine, they aren't always sedated. Actually, horses tend to do better not sedated. And you're going to see that here in some videos I'm going to show you how well and tolerant they are of certain procedures. Um, and of course, you'll see that throughout some of our other modules with other medical procedures. Large animals are really resilient. It's pretty incredible. We tend to sedate a lot more in small animal than we do in large animal, which is kind of surprising. Um, that being said, two different types of endoscopes. So we've got our rigid ones. These ones are straight. They're just a straightforward, usually, 6 to 12 inches long. And these are for things like rhinoscopy, cystoscopy, laparoscopy, arthroscopy, vaginoscopy, thoracoscopy. Um, different types of endoscope procedures. And these, again, it's this rigid piece is comprised of a metal tube that has lenses or glass rods. They're usually less expensive because it's not this really long tubing that has to be flexible. Um, but they do not bend. Or if they do, they don't bend very well. It's not like they're going to break off, so they can really hurt the pet you're working with. Again, sedation is usually going to be the key to help keeping our patients still if we're using a rigid endoscope. For the flexible ones, that's where we don't necessarily need to sedate. I've done endoscope exams on quite a few different horses, didn't have to sedate at all. And again, I'll show you a video to kind of give you a little bit more image of what that looks like. So these flexible endoscopes are actually fiber optic. So they have glass fiber bundles that transmit light. These fibers are super fragile, which means if they break, we get black dots on the monitor. So we have to take really, really good care of these, and they are expensive. So we don't want to be replacing these very often. We want to take really good care of the equipment. Um, and again, it emits a video. So there's a digital chip in this endoscope that will transmit the image to the computer and then it'll pop up on your monitor. The image can be recorded to show the client. We can take pictures from the live video feed as well. There are some different accessory equipment that they may choose to use. It really depends on what they're using the endoscope for. So, of course, we have flexible ones, we have biopsy forceps. If we're doing a gastric endoscope on a horse, we're usually taking biopsies. Even doing the respiratory endoscope exams, we're usually taking biopsies. So, small tissue samples and stuff like that to run for laboratory testing. We also might have like foreign body removal forceps. So, endoscope is really interesting. We can use this on a patient that has swallowed a foreign body if the owners bring them in within a reasonable amount of time. So I had one case. I've only ever seen this once because most of the time owners don't see them eat it, or by the time they realize that they've eaten something, it's been too long and it's already passed into their intestine. So in order to be able to remove a foreign body from the stomach, it still has to be in the stomach. And usually it's only in the stomach for like 2 hours and then it's already moved out. It's a really quick process. So there was only one situation I ever saw this on, and this was a cat that ate a needle, like a small metal little sewing needle. It was this the client was doing a little hand sewing some kind of project, and I guess she set it down, the little needle and thread, and the cat went to like, lick and play with the thread, and she said she turned back around and all she saw was the cat swallowing and the needle going right down the cat's throat. I mean, how scary, right? So she rushes the cat into the clinic that I was working at, and she was a really great client of ours. We worked with her all the time, and we knew her very well. And so we decided, we're like, well, if the cat just ate it, then we should be able to scope them and remove it with a scope. This should be possible. So we sedated the cat, and the doctor went in with the endoscope, and they were actually able to retrieve the needle and pull it back out without damaging the patient's esophagus. It was incredible. I've never seen anything like it. It is possible. Again, time is of the essence. It kind of has to be like a perfect storm to be able to do it this way. Otherwise, if it's a foreign body, we're talking about surgery. We're talking about, exploratory GI surgery, which has a massive recovery time and is way more expensive and all the other things that add to that. So it can be used for foreign body removal. Is it always, doesn't always fit the bill to be able to be used, but it's great if it can. Uh, Cytology brushes or certain other brushes for diagnostic testing can be used as well. When it comes down to some of the common endoscopic procedures that you're going to see, gastrointestinal endoscopy, as I've been talking about, is going to be the most common one. This is when they use the scope and they go down the esophagus and they visualize the stomach, the small intestine, the large intestine. And so again, visualization of the upper and lower digestive tract and the contents. We use the flexible endoscope for this, and they're usually taking tissue biopsy samples. We can also do a colonoscopy, and this is the examination of the transverse colon, the ascending colon, the cecum, and the ileum. This is the large intestine, and they do have to go through the rectum in order to look at the large intestine. Now, we also use the flexible endoscope for this. We technically like to put the patients under general anesthesia if we can. Sedation does work fine for this procedure. It doesn't last a very long time, so it's usually preferred that way. In order to do a colonoscopy, they do have to empty all contents of the bowel. So, just like in human medicine, we do have to give the animals laxatives. We do have to fast them. We do have to make sure that there's no content. Same with gastrointestinal endoscopy. If we're scoping the patient, they should have been fasted at least 12 hours. Bronchoscopy, this is the visualization of the trachea and the bronchi, so like a respiratory type exam. We could be using this as a diagnostic tool to collect sample. We would use the flexible endoscope. There is technically a bronchoscope that we could use as well for this specific procedure. And usually, it says on here general anesthesia, but usually it's sedation because think about it. If we have an endotracheal tube down their trachea, we can't also fit the endoscope down the trachea. So it doesn't work. So usually it's just sedation so that that airway is open so that we can use the camera to view it. A cystoscopy, this is the visualization of the vagina, of the urethra, of the urinary bladder, and the ureters. So we would do cystoscopy. Again, this is diagnostic tool. Usually sample collection could be a part of this. We scope a lot if the patient has been blocked before with urinary crystals. Scoping might be really helpful to get them unblocked and just monitoring of those areas and regions, or if we're suspecting of cancer or incontinence issues, many different reasons why we might want to do a cystoscopy. Now, if it's for a male, we're going to use the flexible cystoscope because their urethra is a long S-curve urethra. It goes up and around their penis. It's kind of, again, it's kind of like an S. So we have to use that flexible cystoscope for them. For the females, their urethra is really short and it's only like an inch or two long, and it goes right to their bladder. So we can use the rigid straight endoscope for that. We could use the flexible one if we wanted to, but the rigid one works just fine. We'll generally put them under general anesthesia for this, inhalant anesthesia. Last one here we're going to look at for today is a rhinoscopy. This is the visualization of the nasopharynx and the nasal passages. So we're looking up the nose. We're looking in the nasal passages. Very common to do this in patients that are brachiocephalic. So any of those patients with the squish face that have that squish nose. So think of like your Frenchies, your pugs, your Persian cats. This can also be done quite a bit in horses. We do rhinoscopy all the time in racehorses to make sure that their airways are cleared, that they're breathing properly. Many different reasons why we might want to do this. Again, it's a diagnostic tool. We also use it for sample collection. We use a flexible bronchoscope or the flexible endoscope. And we can put them under general anesthesia for this. However, sedation works. We don't even need sedation with horses. Okay, before we get into this next topic, which is CT, I want to show you two short videos. The first one is going to be an airway endoscopy procedure on a horse. And then the second one is going to be a gastrointestinal endoscopy with a cat. Okay, let's get into the one with the horse first, and then we'll go to the one with the cat. And again, we're looking at ultrasound. Or sorry, not ultrasound, endoscopy. So this is going to be a upper airway endoscopy, and then the next one is going to be a gastro into the gastrointestinal tract.
Endoscopy is a really useful tool to allow us to investigate and diagnose a range of upper airway diseases and conditions. It is minimally invasive and tolerated extremely well by the patient with just light sedation. It allows us to make a definitive diagnosis and therefore formulate a safe and appropriate treatment plan, not only to achieve a more effective treatment result, but also to reduce the potentially dangerous side effects of treating these respiratory conditions blind. First, we listen to the horse's chest at rest. This is to detect any abnormalities before any exercise is performed and allow us to obtain a resting respiratory rate. Next, the horse is placed onto the lunge. This is to allow us to identify any abnormal breathing sounds, any coughing, and also to mobilise any secretions or discharges within the respiratory tract, which would allow sampling of them to become easier. The horse is then slowly walked into the stocks to allow for easy, comfortable restraint and allow a lower dose of sedation to be used. The horse then has his chest and heart listened to again. This is to detect any changes pre and post lunging, and also to make sure that we are okay to give intravenous sedation prior to the procedure. Once the horse is adequately sedated, the endoscope is lubricated and then passed slowly and gently up one of the nostrils until it reaches the level of the larynx, which is at the back of the throat. As you can see, they tolerate this very well. The aim of the first part of the examination is to visualise the larynx, which marks the entrance to the upper respiratory tract, the trachea or the windpipe. Here we look for the presence of any swellings or masses or growths, that both sides of the larynx are symmetrical, there is no inflammation or reddening, basically that everything looks to be working how it should. Once we are happy, we then advance to the next stage. The endoscope is advanced through the larynx and into the top part of the trachea. Here we are checking that the trachea is a normal size and shape, and also examining the trachea for the presence of any abnormal mucus or secretions. The endoscope is then advanced all the way down the trachea to reach the carina, which is the level at which the trachea splits to form the left and right lung lobes. Once we are happy that a thorough examination of the entire trachea has been performed, a sample of the mucus is taken. This is called a tracheal wash. A sterile catheter is advanced down through the endoscope and a set volume of sterile saline is administered. The saline is then retrieved back through the catheter, bringing with it a sample of the mucus and cells that are present within the trachea. The catheter is then pulled back inside the endoscope before removal, so not to damage the lining of the trachea. The endoscope is then slowly and gently removed from the horse's respiratory tract and nose. The samples are then decanted into mediums to allow for cell preservation and transportation to a laboratory for testing. The patient is then allowed to come round from his sedation in his own time, but as you can see is none the wiser from the procedure he has just undertaken.
Okay, we're now going to go into the next video, which is the feline endoscopy procedure. Again, this is going to be, I believe they're removing actually a foreign body, if I'm not mistaken, with this. Yeah, at the end, he's actually going to pull out, just like what I was talking about with being able to pull out a foreign body, if we catch it within that really fast time frame. So awesome, awesome. We're going to get into this right now.
This is Dr. Hughes. We have a younger cat here that swallowed a possible foreign body. Usually cats love to eat string, any type of yarn, any kind of fishing line. They love to eat long stringy things, and we think there's like a 5-inch piece of yarn. We did an x-ray, and basically on the barium, we gave some barium, and the barium's highlighting some type of foreign body there. So anyway, we're going to do an endoscopy. This is one of the services we offer at Conejo Valley Veterinary Hospital. And it's great because if we can get this foreign body out with an endoscope, this little kitty can go home tonight and doesn't have to spend the night. I don't have to do any surgery, invasive surgery, where I open up the abdomen and actually have to go into the stomach and remove the foreign body that way. And that would be a 2-week recovery on that. So hopefully we'll get lucky. Here we go. So right now, I don't know if the camera's showing this, but we're in the esophagus, and you can actually see the heart beating right up against the esophagus there. So, Caesar, can you see the heart at all?
Yeah, I zoom in a little bit.
Yeah, okay. So now we're going through. Okay, so we're in the stomach now, and we're going to inflate the stomach. We'll see how this goes. Caesar, I might have to have you hold the neck in a second too, so we can inflate it properly. You can see the folds of the stomach right there. Looks like it's inflating everything. Okay, and actually there is the foreign body right there. So what we're going to do, so you can see that's the stomach inflated. Now you can see a little bit of the rugal fold still. And then if you look right there, there is a foreign body. And it looks like the owner told me that it was a blue piece of yarn. And I can see that it actually does look like there's a blue piece of yarn in there. Awesome, let's take it out. All right, Caesar, you have the graspers?
Yep.
Okay. This type of foreign body would have gone down the stomach and would have gotten hung up on one part, and the whole yarn would go down the intestines, and then the intestines would plicate or kind of form an accordion over it, and then the yarn or string serves as a saw. So it can be very fatal if we don't get this out right away. So it's very good that the owner observed this, and we were able to go in here and get it out of the stomach before it actually went down into the intestines. So, all right. Okay, let's see what happens.
Yeah, I can't do that until ready?
Trying to hold the graspers too. Wow. Here it is, guys. Let me give them a close-up here. If we can or not. Let's see. There it is, guys. That's how we remove a gastric foreign body in a dog or cat.
Absolutely wild. Like I was saying, it is so crazy when you see foreign bodies being removed like that with the endoscope. Like I said, I've only ever seen it done once, and it's just incredible that that's something that we can do. All right, y'all, we have 2 more slides left. Let's get into our last 2 slides. So we are looking at CT and then MRI. And I do have 2 short videos to go along with both of those, and then we will be all finished with our chapter 11 slides. So with CT, we were just looking at that with your discussion. That's computed tomography. In a CT scan, this provides cross-section images of all tissues, depending on the area that we're imaging. Tissue density is compared to water in these scans. They use an X-ray tube and multiple detectors in a slip ring device. The patient is stationary and the ring device passes over them to do the imaging. The image is then displayed on the computer monitor that's attached to the machine, and then the doctors are able to evaluate them. By doing this and getting these images, it helps give the visualization of things like disease processes, planning surgical or radiation type treatment. And for all animals, general anesthesia is necessary. So it doesn't matter whether this is a dog or a cat or a horse, we have to put them under general anesthesia. They are not allowed to move during this procedure. Just one moment, y'all. I have to pause the recording here just for a moment. Okay, y'all. So as I was saying with the CT scan, that most patients are going to be under general anesthesia when we're doing this scan. I do have a short video that I'm going to be showing you all. It's just an inside look really quick about CT scanning in the veterinary field. And then once we're done with that, we'll get into MRI and one more video and we'll be all finished. Okay. All right. We are going to get right back into our last slide here for our MRI. So, last of our diagnostic imaging for chapter 11. So, MRI is magnetic resonance imaging. An MRI involves strong external magnetic fields and a variety of radio frequency excitation pulses to get these images. So, what the MRI provides is in this imaging, it'll show visualization of structures and functions of those organs. So it shows the soft tissues, the internal organs. It's considered non-invasive. Same thing with CT. We'd want to put them under anesthesia, as this can be a lengthy, it can take few minutes up to an hour to do these scans, depending on what we're doing. So general anesthesia is usually what's required for this. One last video here that I have about the MRI, just to show you a visual of what these machines look like. Again, we can use this for large animals, but we're usually only using it on things like their extremities or their head and neck. As you can imagine, their full body is not going to be fitting inside one of these, but we can use it for almost anything else. Okay, we'll get started with this last video.
Is a Philips MR 7700 3 Tesla MRI. And it has 65 millitesla per meter gradients, which are very high performance. So this machine is really cutting edge as far as technology, and it's brand new. It's one of the first Philips has installed on the market. Since installing the system in late January, we've already done a number of clinical patients, both equine and small animal. Small animal dogs, cats are our primary users of the system. Our neurology service typically refers those patients in. And then with our equine patients, we're also working on being able to do head imaging, but a lot of what we do is musculoskeletal and scanning of the limbs. So we've had great success already within just the first 2 months of using the system by already seeing the improvements in the signal quality, seeing the improvements in the time, and able to really enhance our protocols to include the latest and greatest pulse sequences for optimal diagnostic imaging and MRI of our patient. Because veterinary patients are small, typically smaller dogs and cats, typically smaller than a human patient, this magnet comes with a lot of features, and being a 3 Tesla allows it to really enhance our signal and generate high quality images in less time. So we're able to image and do newer and the latest and greatest technology and pulse sequences in magnetic resonance imaging. So this system comes equipped with artificial intelligence in a number of capacities. We're able to do deep learning as far as post-processing of the images, able to take pulse sequences that would have normally been a third to twice as long, and through post-processing we're able to shorten that and reduce noise, increase signal, and do data filling in a way that allows us to streamline and optimize images in a faster way. It also helps with operator continuity by ensuring that each person who sits down to scan a patient scans it similarly, and that the slice planning will actually come up in a similar way. So you get more similar scans as the patient initially comes, they come back, or across all canine brains, dog brains, or a horse limb. So we're able to get a lot more continuity in the way our technologists scan the patient. So with this new 3 Tesla Philips MRI, we're going to be at the forefront of medical imaging, especially in veterinary medicine. We're going to be positioned very well for the next 20 years of clinical and research imaging and what we can do for our patients. It's been really impressive to see, and the first 2 months have really far surpassed our expectations. We're super excited and pleased to share this with our community. MRI.
All right. And actually, we are all done. This is it. We're at the end of slide 87. So we are all finished with our PowerPoint for chapter 11 on our radiology procedures and diagnostic imaging. So with that being said, students, I am going to end the recording now.